I'm going to continue with the treatment. I will mainly talk about the 2022 ASAS-EULAR recommendations, which are the most recent ones for the treatment of axial spondyloarthritis and are the ones we usually use in our daily practice. A brief summary of the evolution of the recommendations is that those from 2006 and 2010 only covered radiographic axial spondyloarthritis. The 2016 recommendations already made a distinction between radiographic and non-radiographic forms, and these latest ones from 2022 provide us, in addition to the previous information, with new insights on anti-TNF agents, interleukin-17 inhibitors, and JAK inhibitors. It's important to highlight that most of the data included in these recommendations come from placebo-controlled trials. What we want are trials that compare drugs with other drugs, to give us much more information when it comes to treating a patient in day-to-day practice. The working group is very broad. It included rheumatologists, epidemiologists, EULAR representatives from the Health Professionals Committee, patients with arthritis or rheumatism in Europe, the EULAR Emerging Network, and young ASAS members. And all these recommendations were approved by more than 75% consensus. What do these recommendations offer us compared to those from 2016? Well, they provide more information on both IL-17 and JAK inhibitors. They will make a difference for us in terms of extramusculoskeletal manifestations. They will guide us in determining which treatment we can apply when there is, for example, uveitis or psoriatic arthritis. It also provides us with a tool, the ASDAS, which will help us choose the best candidate when starting and continuing treatment. So what do we have? Well, 2 new recommendations. There are some updates or changes in a few of them, and about half or a bit more remain unchanged. Regarding the general principles, of which there are 5, there are no changes compared to those from 2016. I think it's worth reading them. It tells us that axial spondyloarthritis is a potentially serious disease with diverse manifestations that usually require multidisciplinary management, and it is the rheumatologist who should coordinate that management. The main goal of treating a patient with axial spondyloarthritis is to maximize health-related quality of life through symptom and inflammation control, prevention of potential damage that may occur, and to preserve or restore normal function and social participation. Optimal management of these patients requires both pharmacological and non-pharmacological measures, and the treatment should aim for the best care as well as a shared decision-making process with the patient. It also carries many costs at the individual, medical, and social levels, which we must take into account. The first recommendation has a small change, which is that it now specifically mentions that the extra-articular manifestations are uveitis, psoriasis, and inflammatory bowel disease. And it mentions comorbidities because they have a significant impact on the diagnosis, outcomes, and treatment of the disease. Regarding recommendations 2 and 3, there are no changes. It tells us that to monitor a patient, what should we do? What we normally do is rely on clinical findings, lab tests, and imaging studies. And how often should we carry out that monitoring? Well, actually, at every visit and depending on the symptoms. If the patient has more symptoms, we move the visit forward. And the treatment should indeed be guided according to a goal that we must have predefined beforehand. These 2 recommendations, numbers 4 and 5, also have a small change. And in recommendation 4, what we should encourage patients to do is to exercise and quit smoking, and in general, to adopt healthy lifestyle habits. And here there's a change. Rather than saying physical therapy, it now refers to physiotherapy. And studies have shown that supervised physical exercise led by a professional is more effective than doing physical exercise at home on our own. Although it's still recommended, it points out that supervised exercise is more effective than doing it on our own. That doesn't mean we shouldn't tell them to keep exercising. Then, recommendation 5 is that patients with pain and stiffness should use an anti-inflammatory as the first line of treatment. up to the maximum dose, always taking into account the risks and benefits. And for those patients who respond well to NSAIDs, it is preferable to maintain continuous treatment with the anti-inflammatory if they continue to have symptoms, rather than using it on an as-needed basis. That's the change. Regarding recommendations 6, 7, and 8, there are no changes compared to those from 2016. And it states that we can use pain-relieving medications such as paracetamol or opioid derivatives when there is residual pain that cannot be controlled with other medications. For example, when there are peripheral manifestations, in particular, glucocorticoid injections can be used, but they are not recommended for long-term use in patients with axial spondyloarthritis who are taking systemic corticosteroids. And it also informs us that patients who have purely axial disease in any case should not be treated with conventional synthetic drugs such as methotrexate. However, we could consider sulfasalazine for those patients with peripheral arthritis. Once we have made the clinical diagnosis of spondyloarthritis, the first thing, as we mentioned before, is to tell the patient that if they are smoking, they should quit the habit, or if they are planning to start smoking, tell them not to. We should also encourage them to engage in regular physical exercise and educate them about the disease, explain what the disease is, what possible complications may arise, and of course address all their questions. In addition, we can complement this with physiotherapy, and if the patient is symptomatic, we start anti-inflammatory treatment. After 2 to 4 weeks, we reassess the patient. On one hand, has there been a sufficient response? If so, we continue with the treatment. If not, then we start a new cycle with anti-inflammatories and reassess again. After 2 cycles with anti-inflammatories, we ask ourselves, has there been a sufficient response? Well, if not, we move to the right-hand branch, which would be if the patient reports peripheral manifestations, and we could use intra-articular glucocorticoids or sulfasalazine. And on the other hand, if the patient reports axial symptoms, these guidelines suggest starting with an anti-TNF, an interleukin-17 inhibitor, or a JAK inhibitor. And also in the case of a patient with peripheral axial spondyloarthritis who does not respond to treatment on this side, then they would also move on to start biological therapy. The guidelines propose that although there are those 3 drugs, due to the fact that there are more studies and more evidence, the recommendation is to start with an anti-TNF or an interleukin-17 inhibitor. At 12 weeks, we reassess the patient. If there is an improvement in the ASDAS of at least 1.1, we continue the treatment. If not, we need to reassess the patient again. Then we ask ourselves, have we made the correct diagnosis? Based on everything Esther has explained to us, does the patient have more comorbidities? Then we try to treat them. And if the patient still has lower back pain or peripheral manifestations, then we switch the target or the drug class. If we started with an anti-TNF, any of the 3 options is valid. In the case that we started with an IL-17, these recommendations also do not favor one over the other. We reassess the patient again at 12 weeks. Is there improvement? We continue the treatment. Later on, we'll discuss for how long. And if there hasn't been any improvement and the patient has already gone through 2 lines of treatment, we need to reassess the patient again. We need to see what's going on. So we would consider performing additional tests and digging deeper into the medical history. Regarding recommendation number 9, there is a small update that I've already mentioned, which is that when patients have high axial clinical activity, we can start with any of the following: anti-TNF, IL-17, or JAK inhibitor. However, in current practice, these recommendations state that treatment should begin with either an anti-TNF or IL-17. And what is the update? Well, in the previous 2016 guidelines, it stated that treatment should begin with an anti-TNF, but now they've added the interleukin-17 inhibitor as an initial therapy option as well. Therefore, in a patient who has been diagnosed with spondyloarthritis by the rheumatologist, who also has elevated CRP levels and positive imaging findings on both MRI and X-ray, and who has failed standard treatment, meaning they have received 2 courses of anti-inflammatories, or if they had peripheral symptoms, they have received intra-articular glucocorticoids or sulfasalazine, on top of having high disease activity, and we believe treatment should be initiated, then we start it. And with what? I repeat, either an anti-TNF, an IL-17 inhibitor, or a JAK inhibitor. This recommendation number 10 is new and tells us that when we have extra musculoskeletal manifestations, which treatment should we lean towards? If uveitis or inflammatory bowel disease predominates, they tell us that we should use or start with a monoclonal anti-TNF alpha antibody, and that etanercept and secukinumab should not be used in such cases, in active inflammatory bowel disease. And therefore, if we have a predominance of psoriasis, that is a skin disease, we should start with an interleukin-17 inhibitor. Another new recommendation is number 11, which states that when we do not have a favorable response to treatment, even though we believe we have treated the patient properly, we must reassess quickly whether we have made the correct diagnosis and consider if there are other comorbidities. Recommendation number 12 comprises a small update which tells us that, importantly, after the failure of a first biologic, it is important to note that or a JAK inhibitor switching to another biologic or another JAK inhibitor should be considered. There is fairly limited evidence on the effectiveness of switching from one biologic to another after failure of the previous biologic treatment. It does tell us that if we have used an anti-TNF, we can then use another anti-TNF because it has been shown to be effective. After an anti-TNF, we can use an IL-17 or a JAK inhibitor. It does not favor any specific treatment to use after the failure of the first biologic. In these latest recommendations, there is no change compared to those from 2016. Recommendation 13 tells us that if the patient is in sustained remission, a gradual reduction of the drug should be considered. We'll talk more about that later. And these recommendations state that total hip arthroplasty should be considered in patients with refractory pain or disability, regardless of age. And that if a significant change occurs in the course of the disease due to a cause other than inflammation, it should be taken into account. All right? To summarize, these are recommendations. Then, when we have the patient in front of us, we need to assess and decide what to do. I'm going to talk about the treatments that are approved for axial spondyloarthritis. First, all the anti-TNFs, the IL-17 inhibitors, ixekizumab, secukinumab, and bimekizumab. And the inhibitors now include tofacitinib and upadacitinib. And sulfasalazine. What we need to keep in mind when prescribing an anti-TNF is that there are several contraindications, but above all, we should not use it if there is a demyelinating disease, pulmonary fibrosis, or if the patient has congestive heart failure classified as NYHA class 3 to 4. And the rest? The JAK inhibitors, indeed, there have been studies linking them to a higher cardiovascular risk in patients over 65 years old or over 50 with a history of deep vein thrombosis or pulmonary embolism. That's something to consider when deciding on the treatment we prescribe for our patients.